First of all, thank you very much for inviting me to speak today. It's a real pleasure to be here. There's been some really interesting talks and some really interesting themes. I hope that my presentation will build on this a little bit. I'm just going to talk about age-related changes in gait and balance, particularly looking at kind of measurement methods to try and inform clinical understanding. And I'm going to look at frailty in the ageing population. A lot of this work was done in collaboration with Helen Dawes, who spoke earlier, and my colleague Andrew Waitman, who was on the panel earlier as well. So when we're looking at healthcare challenges, obviously, as we're moving towards 2050 and lots of healthcare agencies are looking at that, we've got this growing ageing population. We've got poor balance in the elderly population that's leading to problems with healthcare and decreased quality of life. And we've actually got a reduction in spending in real world terms, and this has really been going on for decades now. So there's major problems, and we've been talking today about what the future perspectives are with regard to healthcare technologies. And it's great that 34% of countries, a lot of countries around the world now have healthcare technology as part of their solution for healthcare provision, and the UK is one of them, and many other nations are the same. Again, it's great that government is backing this with various different funding initiatives as well to try and help develop new healthcare technologies. But how can these help for healthcare technologies for older adults? Well, I think in terms of prevention and early detection, I think we had that before in the keynote when we were talking about that. In terms of care and support, in terms of rehabilitation and mobility and improving balance, and then also maybe in terms of community and quality of life as well. So we'd hope to be able to develop this concept of assistive healthcare. And I guess this is actually an AI generated image of maybe having sensors on an older person, an older adult, and then this is processed by AI, and it's giving some biofeedback via their mobile phone. And this is maybe, as a technologist, what many journals are filled with, solutions like this. But there's problems with the technology in terms of thinking about it in this kind of way. Often there are too many sensors. I don't think we change that much from being a younger person to being an older person. We just want to live our lives. We want to be unimpeded and to be able to be, free just to, go about our daily activities. So, too many sensors. I think really we need to be looking at solutions which are just single sensor in order to make these things effective. Similarly about, AI is branded as this magic bullet that will solve all kinds of problems. But it needs some guidance in order to do the solutions properly. And then also biofeedback. I think this lady here, sorry, I don't know your name, said, so what? What's going to happen with this? And I think really we need biofeedback or clinical information to be going back to the patient or the clinician in some meaningful way. So we did a project which was funded by EPSRC, Digital Physio OT. My colleague, Professor Dawes, spoke about the OT part of this earlier on. I'm going to talk a little bit more about the physio part of this. Ironic, I'm not the physio, Helen is the physio here to talk about this, but this was a real team effort between, a number of my colleagues here as well. And we were really asking the question about what does it mean to have good balance? And I think in the keynote we were talking about yes, we might be able to prevent falls or measure when a fall happens, but really it's about, could we prevent that earlier on? What are the factors that are happening there? And talking about dosage and what's happening over time. So, things in the literature in terms of static balance is really well defined. We understand this about base of support and center of mass staying within there, but actually a lot of the activities of daily living are not static, they're moving and they're changing. And we need to understand what's happening in terms of dynamic balance. And if people don't fall over, then we could probably say they're dynamically balanced. If people are falling over, then they're not dynamically balanced. So we're asking questions about how are they dynamically balanced, and also what do they do to be dynamically balanced? So in this project, we were aiming to determine and evaluate a clinically useful measure of dynamic balance and apply this to an activity of daily living. In our case, we looked at sit to stand. And the methods that we used, we looked at a lit review, and then we also did an experimental study and some analysis, which we felt could then go through in terms of a healthcare technology. So in our literature search, looking through the literature, I think we looked at, about 362 different studies. We found there were about 17 that were specifically identifying dynamic balance, and there were about 35 which were identifying definitions for static balance. Static balance talked about, the definition I talked about before, and then also looked at centre of pressure, movement and displacement that was happening there. And there were just really these two definitions for static balance. Conversely, for dynamic balance, there were a lot of different definitions. And the conclusion that we really came to from our lit review was that static balance really well defined, but dynamic balance not very well defined, and none of those definitions really translated very well to wearable sensor technology and use of that within a clinical setting. So this was a real problem. I think it's a barrier to be able to use these tools effectively for falls prevention, for improvement of balance over time. So we looked at sit to stand analysis as kind of a case study for an activity of daily living. This is really important, for many things, getting out of bed, going to the toilet, going to make a drink or whatever you might be doing in there. So we were looking at, what might need to be measured. And if we were doing a gait study within the gait lab or within a university setting, we'd probably have some kind of model as to what's happening. And then from that, we would be adding sensors all over the place to be able to map what's happening with all of the body segments on there. But this isn't really clinically practical, and people aren't going to adhere to this within the real world. So we were looking for something simpler, which would still output some measurable things that would be related to balance, that would be able to be clinically useful. So we used some inverted pendulum models, and we linked this just to a single sensor location. And we were trying to use an energy method, really saying that, the kinetic energy of the person plus the work that they're able to do needs to be greater than that potential energy of them falling over. And we mapped this to our model that we'd got in here. So our methods, this is just applied to just one older adult, one younger adult here, just for the purposes of demonstration on here. We did some data collection within our gait lab, as well as with the IMU that we'd got here, and processed this data. We analysed the stages of sit to stand and split this up into some logical stages to be able to enable us to do our method on here, and then mapped it to our new method, and then observed differences between these participants. So these are our sets of results that we got out on here, and we were looking for characteristic changes that we'd got on here. So first of all, we'd got higher initial velocities within our younger adult. We'd got larger force production to kind of correct these initial velocities and stop people from falling over. And then we also looked at the energy that was happening here. And we found that we'd got kind of longer duration of sit to stand in older adults, which is, I guess, what we probably observe. And we had kind of larger kinetic energy at bottom off for younger adults in comparison to older adults. Also, we had more hip joint energy during leaning for younger adults. Maybe just skipping through here, but some of the things that are quite important is that older adults used a lot more energy in order to actually perform these movements, which I think is really important, and trying to learn about these things to come through. So in conclusion for these things, really what I think is important is that we really need kind of single sensor technologies, and research has shown that I guess people will tolerate wearing a watch or a wristband, or maybe having a belt sensor or insoles, but they don't want things that are going to interfere with their daily lives. Also, we need to give guidance to things like AI, and I think there's a real role for biomechanists and clinicians to feed into that guidance, and that AI isn't really just a magic bullet that will sort everything out without this guidance in order to do those things. Also, biofeedback is really important, and having that either in a I guess a user-friendly way, coming back to them to help them maybe retrain gait or change the strategy in which they're doing those movements, or informing the clinician in a particular way. In our case, we were looking at energy, looking at things to do with kinematics, which might be able to come through on there. And we're hoping to continue this work further to really look at a larger cohort study, and also use these IMU measurements coupled with practical measures of movement and AI to give us better biofeedback and hopefully lead to improvements in daily living. So thank you very much for listening. And again, this work wasn't just done by me, it was done by a huge range of other people on our funded project. Okay, thank you very much.